So I'm pleased to say that Elaine and Kyle have made my talk a little bit easier, although a little bit more difficult because they did such a good job in trying to demystify, so I'll try and avoid jargon as much as possible. So I'm going to start off with the basics. So what are the goals of all of us for childhood cancer? Well, very simply, we want to actually cure everybody. And of course, we've been doing that for many years in terms of clinical research, and I'm going to promote clinical trials and clinical research. And you can see over the decades that the actual survival rate overall for childhood cancer has improved. But unfortunately, what we know is it's now plateauing. And that may well be that we've actually optimized our conventional treatments such as surgery, radiotherapy, and cytotoxic chemotherapy. But the other goal, of course, is not only do we want the highest survival, but we want the lowest cost for that survival. So we want to decrease the burden of treatment. Now, hopefully, it's not a seesaw. Hopefully, actually, we can do both at the same time. But there are two goals often that we're looking for in terms of trials and developing novel treatments. So where do treatments come from? And this is what Kyle and Elaine have actually talked about. This very somewhat old-fashioned process in terms of screening drugs, often cytotoxics, just generically across cell lines in the laboratory. And it can take many, many years in order for this to actually go through. And Kyle's also mentioned that it's a very wasteful business, a very expensive business, and indeed, here's a graph to show you that he was right, that the oncology drugs have got the lowest hit rate in regards, and they cost an absolute fortune to develop. So the hope was that actually by better understanding of what actually causes cancer is that we could actually speed up this development, refine it, and get more drugs. Really the advent of this was the increased knowledge of the library, the dictionary of the human genome, which actually, of course, helped us to differentiate between a normal cell and a cancer cell and some of the differences between that. And that actually led to a change in oncology pipeline. So instead of cytotoxic chemotherapy in adult cancer, from some years ago now, the licensing was mainly for targeted therapies, and that included antibodies, such as the ones described by Elaine, but it also included small molecules that were targeted against specific mutations. And really, this has been a complete change in the field of adult cancer. But in pediatrics, it's taken us a very long time to actually be coming forward with drugs that may actually go into frontline therapy. And again, Carl's already explained to you that, in fact, the majority of the treatments, albeit successful as they often are based on drugs that were developed in the 1940s, 50s, and 60s. So Carl's talked about two different types of drug discovery. One where you actually specifically look at the biology, and you have a target from this genetic analysis, and then you actually go through this whole process of trying to actually see whether it's important for the cancer cell. Can you actually target the cancer cell with techniques, drugs, which we do in the laboratory with cell lines, such as Carl's work, but also with preclinical modeling in animals, and then take it forward to a trial. So has genomic research impacted on childhood cancer? I think there's been a massive impact. In fact, it's changed the way that we work. So actually, I look after patients with brain tumours most of the time, and my research is mostly directed. Now, only a few years ago, we would have called tumours a particular type by our pathologists looking under the microscope and grouping these. But now, in everyday practice, certainly in my own unit, we would perform molecular analysis and subtype these patients, which actually mean that we've got new clues, but it's also made life very, very difficult. And you don't have to read these, but these are basically subtypes of different childhood cancers, and they're based on molecular findings. And what we're obviously using is these molecular findings to better treat childhood cancer. And indeed, only last year, the whole way that we classify brain tumours was altered because of this data. So this is used in routine practice now. So you heard this word biomarker. So what does it mean? Well, actually, all it means is it's a tool, usually a test, but it doesn't even have to be a test, that we can actually use to help us to treat patients and to design therapies. So a biomarker, this test, can be used to help diagnose more accurately a cancer or a disease. It can be used to classify a disease. It can be used to define a risk grouping. So patients who have a particular tumour type but actually may do well in standard treatment, or they may actually have a higher risk. And that helps us with prognosis, how a child will actually do. It allows us, therefore, to potentially select patients on the basis of grouping, because it may be that we want to select a group of patients who actually currently do very well with conventional treatment, where our main aim is to reduce the toxicity and reduce the burden of treatment, versus those patients who may have the same disease when looked just under the microscope, who do badly, who, of course, we want to actually perhaps treat more intensively or have new treatments to improve their survival. So it allows us to actually do different things, sometimes in what used to be the same group of diseases. It also allows us to measure the effect of the drug. So if we have a targeted drug, we want to know that it's actually working by hitting that target. And actually, we can use tests to tell us it's doing that. And we can use tests to monitor the toxicity of treatment as well, which is important. And of course, ideally, what we'd like to do is monitor for relapse. We ideally wouldn't wait for our patients to have a tumour grow to be developing symptoms, but we would have a test that we're using all the time to tell us in advance that actually something's going wrong with our treatment, and we would alter it. We would anticipate and actually change the treatment before the patient actually presented in the normal way. So what types of tests do we use? Well, the most simple can literally be the clinical diagnosis. Sometimes even gender may have an impact. So actually you don't need any fancy test to know the gender. But actually quite often, as we've said, it will be a test. It could be the tumour itself from surgery or from a biopsy. And that could be conventional pathology. But increasingly it will be some form of molecular testing. But we can also look at blood, at urine, and other bodily fluids, either as surrogate tests. It could be that we're testing for some secretion of a tumour marker. We've been doing that for many years. In germ cell tumours, in neuroblastoma, we've been measuring these and monitoring treatment. So not everything is new about biomarkers. But we've got emerging tests that we can do. We know that tumours tend to shed either cells or fragments of cells, allowing the DNA to actually be found in circulating blood, in fluid, so in my area of interest in cerebrospinal fluid, which cushions the brain and spine. And that means that you can potentially do an easier test than a tumour biopsy to look for the abnormal tumour DNA and actually do that repeatedly, so continuously test. And we're doing a lot of experiments now on samples that we've collected over many years where we could actually use these liquid biopsies and actually predict and potentially help to monitor patients better. We can use surrogate tissue as well, but some of these are invasive. It can be skin biopsies, which of course for children may be invasive, but we can also, as source of proliferating cells, pluck hair cells and look at those as surrogates, mainly for toxicity, or use cheek swabs, etc., just like the bone marrow transplant people. And of course, increasingly, we can actually start to look at images in a different way rather than just measuring the size of a tumour. So there are many forms of biomarkers. Here's an example of a trial that I did many years ago with CRUK, where we looked at a drug which is called an aurora kinase inhibitor, and we knew what it did. And we wanted to know whether it was actually doing that in the dose that we'd actually given to the children. At that time, the only way we could do it was actually by doing a small skin biopsy from the patient before they had the drug and after they had the drug, and we were able to confirm that the drug was doing that, and actually we'd got the right dose on the basis of that. So it helped us to design the trial and to dose the drug correctly. Of course, we've talked about the idea of liquid biopsy, where we actually use bodily fluids to try and look at abnormal tumour DNA, and this is a large area of investment for ourselves. And of course, we can use scans in a different way other than measurement to actually look at the metabolism of tumour cells, either by PET scans or by looking at spectroscopy. And these are techniques which have been used. So how do we use biomarkers? Well, one of the big things is obviously using these tests to direct a treatment. So this comes into the area of precision medicine. So we use a test, a biomarker, to actually tell us what type of tumour a patient has, when they actually might need a treatment, and what that treatment may be. That's the whole idea behind precision medicine. Now, all of this is possible because these molecular markers, which are increasingly the emerging ones, have actually been founded in the major projects documenting the Human Genome Project, which were massive projects taking many years, using many countries, very expensive. But technology has meant that this has become faster, quicker, and just more feasible to actually do in individual patients. The technology is advancing the whole time to facilitate this. So what are the potential benefits of using these biomarkers in precision therapy? Well, the hope is that it will give improved diagnosis and risk stratification, and that is true. So we have already done that in paediatric cancer. That we will recognise that in some patients, and particularly in children, there may be a reason that they develop tumours, and it could be that they have an underlying germline mutation that predisposes them. And that's important because sometimes it'll alter the treatment that we want to actually prescribe to a patient. And it also allows, if appropriate, to screen both the patient and family for potential subsequent tumours. Of course, for trials, we'd like to be able to select patients in a more sensible way and to allocate treatments. And of course, what we're going to talk about is that some patients may have a particular mutation where there's a drug, so we can give them targeted therapies. And we would also like to use biomarkers to analyse who responds, so to analyse responses. So moving to targeted therapies in childhood cancer, I'm going to give you a few examples. So neuroblastoma, unfortunately, is one of the most common childhood solid tumours. High-risk patients are treated with very intensive treatment, a combination of cytotoxic chemotherapy, surgery, radiotherapy, immunotherapy, using anti-GD2 antibodies, but still, unfortunately, many patients succumb. What we knew was that there were subgroups, and in fact, some of these subgroups have specific molecular alterations, either enriched in relapse, which is important because those are often patients that need new therapies, or indeed some patients may have these germline mutations. And this particular mutation here is called an ALK mutation that was actually being investigated and looked in lung cancer, and actually drugs have been developed for lung cancer. The mutations are slightly different, but we've been able to look at the similar drugs being developed, and actually, when we know a patient has an ALK mutation, actually test those drugs. And here's an example of a patient who's responded. Now, in fact, this would only actually be a very small number of patients that would actually respond to this. And if you just tried this to be tested in the old-fashioned way, it would look like an unsuccessful treatment because you weren't selecting patients on the basis of the target. This is a very rare tumour, and actually, interestingly, in paediatric oncology, quite a large number of our patients have very rare tumours. We're now finding that many of these have got an underlying molecular alteration. And in this particular myofibroblastic tumour, again, we can find a different type of ALK mutation where we can give this oral drug. And as you can see, there's been a very good response here for this metastatic lesion. Now, is this only going to be in small rare groups? Well, I think we're starting to get to the point where targeted therapies could have a major impact on some larger groups. And I'm going to share some work that I've been involved with regards targeted therapies and paediatric brain tumours. We've known about the BRAF gene for some time because it's affected in melanoma. And what we found subsequently on analysing paediatric tumours is the BRAF gene is altered in quite a few different types of tumours. And in this particular case, there's a particular mutation called V600. Luckily for us, that's the same mutation in adult melanoma, and drugs have been developed specifically to target that. So we tested a drug developed for melanoma. If you like, this is repurposing, but it's actually for the correct target, in patients who just had to have the mutation. So it was a whole different group, and this is what's called a basket study. And I'm giving you some examples of patients I've treated. So this is a patient with a high-grade glioma. Normally, a patient with a relapsed high-grade glioma after conventional treatment, unfortunately, would be expected to die within 3 to 4 months of relapse. This patient was treated with an oral drug. This is her scan at 68 weeks later, and you can see that her tumour has shrunk. And in fact, she remains on treatment now, over 2 years later. In fact, on a combination, because her tumour started to grow, and we added in a second inhibitor, and she's re-responded by actually analysing her tumour. This is a patient with a low-grade glioma, and this is a very young child who, unfortunately, again, had had a lot of treatment, but we wanted to avoid radiotherapy or proton beam therapy because it would damage the normal brain. So we analysed the tumour and found it had a V600 mutation. Again, the child took an oral drug, and this was just within 8 weeks. And I think you can probably see there's been a dramatic response in terms of the response to this tumour. This has continued to shrink, and the child remains on treatment 6 months later. And we actually have a number of examples. And in fact, we reported on our low-grade glioma experience from this particular drug in autumn at this particular conference. And all these patients had a low-grade glioma but the V600 mutation, this particular targeted drug. This graph simply means that these are measurements of the tumour size. If it's below the line, it's shrunk. If it's above the line, it actually is increased. And normally, using conventional chemotherapy, we would have a mixture of responses. In this case, every single patient has actually responded on what's called a waterfall plot, and the duration of response was durable. As you can see, these are in days, so patients who are 500 days out, so we're talking about coming on to 2 years, etc. And the majority of these patients remain on study. So this looks really promising, but how is these biomarkers and precision medicines going to be? Well, there's now starting to be a lot of reports, particularly from the States, but also from Europe, about applying these across whole populations, particularly relapsed populations. And I think it's exciting, but there needs to be a bit of a caveat. And the caveat is that when you actually look, some people actually report that 40 or 50% tested will actually have a mutation that is amenable to treatment. But in reality, it probably looks out that only 3 to 16% will be able to receive that because there may not be a drug for that target yet. It may not have been proven. So just be aware of the headlines that sometimes are pushed. But I think there is, obviously, for some patients, and I've shown you an example of a group where it may be for the majority, that targeted therapies and biomarkers can help. So what are we doing? There's the 100,000 Genome Project's been going for some time. And we're enrolling patients with childhood cancer onto this, and it's possible that if there's any parents of children who have active treatment, you may be asked. But more specifically, we've been looking at a study called Stratified Medicine Paediatrics, where we actually look in relapse patients, and this is being led by a group of us, and particularly by colleagues at the Institute of Cancer Research. They pioneered this with a particular customized panel for paediatrics, supported, I don't know if Kevin and Karen are in the audience this time, but by Christopher's Smile, and really got this up and going. And actually this feasibility study has been shown that we can actually accrue patients, we can do the testing, and particularly from the Marsden and Great Ormond Street, we've been pulling a lot of patients in to deliver molecular analysis of relapsed patients in a timely manner. Now we want to go further. We want to now do this across the whole country, and we've got support from Children with Cancer. Recently, although we don't know the exact money, we've also got support from CRUK to actually roll this out to do more analysis. And the idea is that we will actually look at this analysis on a national basis to inform doctors who will then actually pass on to families if the analysis has allowed them to have an option of a clinical trial or a targeted therapy at the time of relapse. Here's an example of a study that will use this, eSmart, where there are multiple arms based on targeted agents, sometimes with standard treatments, where you need a biomarker, a test, and the platform we've just described will provide this for the UK. This is already ongoing in France, because we actually get rare populations, so we need to work together globally on this. So in summary, biomarkers have already been used for many years, but they're increasingly more complex. They're increasingly being used to select patients for treatment, and they are increasingly precise. Targeted therapies have become common in adult cancers, but there's been a slow introduction into pediatric tumours. But now, due to the greater molecular analysis and actually some changes allowing for drug companies to actually be incentivized to treat in children and TYA patients, we are getting access to these, and you can see from the examples I gave you that we believe these will move to frontline therapy soon. So I think that biomarkers and targeted therapies are not the answer to all of our problems, but they're part of it, as you've heard about the other initiatives with immunotherapy and repurposing. So thank you.